and we actually have expert people with us, but I think audience is very less. I don't know why. So the first topic what I am going to cover is ocular ultrasonography in retinal disorders. Ultrasound, as you know, is basically a sound which is inaudible to the ears, and it has got a frequency of 20 kilohertz or 20,000 oscillations. This is just basics. I am just talking about few slides, and then we'll go to examples. And we have the various indications in the opaque medium: the edema, torsography, keratoprosthesis, corneal opacities, hyphema, hypopyon, meiosis, pupillary membranes, cataract, and vitreous opacities. Even in clear medium, we have certain the indications, especially the intraocular tumors, differentiation between it is a cystic mass, it is a hemangioma, or it is a tumor. Then we have the most important thing in ultrasound to understand is the echo. Whenever the sound goes, it has to come back, and that is basically called an echo, which actually depends upon these various factors. To start with, we have the angle of incidence. Supposing it is perpendicular, we have the maximum echo. If it is like this, still less, and still further less. Then again, it also depends upon the surface. Supposing it is as smooth as straight like retina, it will be totally, we will get the maximum echo. Then convex as a collar button in melanoma, still dispersed. But if we have a small surface like a clump of cells, everything is dispersed, and we get a very, very small echo. And these are just basics, that you have a machine where when the pulsar gives the wave, comes back, receives, and displays. This is the basically probe what we have in our hand. It has a piezoelectric crystal here. Electric pulse comes, it just changes its shape, a sound is produced, and these are the sounds. In between space is a receiver. Depending upon the various frequencies, more the frequency, less the depth, less the wavelength. So we have 50 megahertz for UBM, 8 to 10 for ocular ultrasound, and 1 to 5 for abdominal. Gain basically is that when this echo comes back, sometimes it is so feeble that you just like जैसे रेडियो में ट्यून करते थे पहले, we just have to increase the gain or decrease the gain so that we can amplify. The more the gain you use, that means the feeble the echo is. B scan, these are the dots you see in the illumination, basically tells us what is the intensity of the echo. And A scan, the height of this basically spike will tell you what is the strength of the echo. Then these are the three positions where the probe is kept, and every probe has got a marker, and this marker is basically tells us that how we are keeping our probe. It can be transverse, longitudinal, or axial, depending upon what area basically we are going to look into the retina. Here we must understand that when we keep a probe in the transverse position, it basically goes from anterior to posterior, and the sound waves go from posterior to anterior. This is one thing very, very important to understand. And similarly in the longitudinal, the meridian which you are going to see, again it is from posterior to anterior, but probe is going from anterior to posterior. And axial is basically on the cornea, either horizontal or vertical, when we are studying the macula and the disc. Then these are the basic screening techniques. When you start using, you will just need to come to know. Only one important thing is that you must see 4 quadrants and 4 meridians in all the cases, and for axial scan, a horizontal and the vertical. And only thing here to remember is that the marker is basically will represent the superior on the screen. Then these are various reflectivity patterns, and important thing to remember here is that the spike strength is 80 to 100 is the highest, and 0 to 5 is extremely low. Then kinetic echography is that certain structures in the eye, they just keep on moving whether you move the probe or not. If it is a spontaneous, then it is a vascular blood flow. If it is after movements, it could be vitreous opacity, membrane, or PVD or retina. And some tips I must give you, that if you are doing ultrasound, a gain setting at 57, if you see a shadow and you just reduce the gain and you will find that that membrane is still there, then it has to be a retina. And the other see, supposing they are vitreous debris, they are only visible at 80, and if you reduce the gain, they will just disappear. Then this basically formula I made when I used to teach ultrasound in my classes. Less risk. You have to go for location, extension, shape, reflectivity, internal structure, sound attenuation, and comparison. So if you keep this particular sequence in your mind, you will never miss a ultrasound finding, as well as it will help you to interpret what we are basically seeing. So to start the examples, first we have to see the vitreous debris. The vitreous debris could be 4 types. One, it can be an asteroid hyalosis, the degeneration. Then it can be an hemorrhage, it could be a subretinal bleed, or it can be endophthalmitis. And if you will find that all of them give you a different type of echo. Supposing it is asteroid hyalosis, it got calcium soaps. So you will definitely get very, very high spikes or point-like echoes, and there will be definitely a space between the posterior boundary of this and the PVD and the highlight phase. Then hemorrhage, always a fresh hemorrhage will give you a very, very small and low amplitude echoes. But as hemorrhage organizes and the membranes are produced, then definitely you will find that these echoes becomes much stronger. But here one thing you must remember, that one type of hemorrhage, which is retrohyalite, will never coagulate, and it remains for a longer time and doesn't produce any membrane. Then the endophthalmitis, again, it will give you a very, very low amplitude, but unless and until when it becomes organized, then you will get the membranes and you will get a high altitude echoes. So this is what basically is the peak, that this first peak is supposed to be the reference peak. We always compare all other peaks as compared to the reference peak, and this is the retina peak, this one is, and then it goes down and attenuates. Now the you see these two videos, this is basically showing endophthalmitis in an early phase and in a late phase. Early phase you will find that these are the various clump of cells you are seeing, very, very low reflectivity. But as you will reduce the gain here, you will find that all these debris will go. But here you will find that this doesn't go, even reduce the gain, and these membranes they formed and additions are being formed in this particular area. There is a retinochoroidal thickening also. See, this everything is gone when we reduce the gain, but here they are still present, and you will, this way we know that this is an old case of endophthalmitis and this is a fresh case of endophthalmitis. Then the next is a case of a vitreous hemorrhage. Vitreous hemorrhage is a very tricky case, because the only we have to manage by ultrasound only. We call the patient every 2 weeks and we do an ultrasound, and as soon as we get that there is a chance of tractional retinal detachment, we always go for surgery, and that is basically a warning sign. So here what we are doing is that we are reducing the gain, and we are trying to find that most of this echoes they are going, and finally what we get is you can see here these 4 settings, and the last setting you will ये फिर कहाँ चला गया यार. You will find here this is basically TRD, or the tractional retinal detachment, which you are looking for. There are 4 different stages. This is early when we start and we reduce the gain, we reduce the further gain, and finally we get a tractional retinal detachment at the end. Now, the three various differential diagnoses always come into mind is the PVD, RD and the choroidal detachment. In my opinion, the most important differentiation point is the spike height. I think if you keep this in your mind, then you will definitely be able to. Sometimes PVD is so thick that you don't know whether it is a PVD or it is a retinal detachment. Then, in my opinion, these are the most important, that if it is a 100% amplitude and there is an aura serrata attachment, then it has to be a retinal detachment. But in this case, it will always be less than 100, means once you reduce the echo, this thing, then you will find that this particular will go away. And this particular has got a very, very important thing, that it has got a double peaked spike with an 100% amplitude. So I have got a video for this also, and you will see here. Here you can see PVD, this is retinal detachment, and they are two are looking almost similar. So, but you can only differentiate when you have that previous chart in your mind. Here you can again see 1, 2. So these are basically very confusing points. The more you do, the more you practice, the more you learn. Only thing you remember is that if you reduce the gain and the shadow goes, then it is most likely going to be a PVD. Then the scleral rupture. It is a very, very important diagnosis. Only ultrasound can diagnose in a trauma patient that whether there is a posterior scleral rupture or not. And there is no directly you can make a diagnosis, yes, this is a scleral rupture. We only have hints. And what are the hints we have? The most important is that everything you will find will go into the posterior surface of the eyeball, and everything is going into that area as if there is a posterior rupture. It can be a vitreous incarnation, detachment, hemorrhage, and finally everything goes and leads to the scleral rupture. You must look for a intraocular foreign body or a textured retinal detachment in a case of trauma. And finally, I must say that intraocular foreign body ultrasound is the most important diagnostic tool we have to localize a foreign body. And the only thing which I must tell you is always look for this shadow behind the foreign body which you are seeing. It is called sound attenuation. And as foreign body is very solid, the most of the ray which I showed you, sound waves, they are reflected back and you don't see anything behind it, and this basically causes, which is called, see, if I am reducing the gain, everything is gone, but only the shadow of the foreign body remains. This is the key feature we must learn for the diagnosis of an intraocular foreign body. Then the most important which I told you is that if there is a clear medium and you have to differentiate that which type of tumor mass we are dealing with, then we have to basically understand this. There is a echogenic mass classification which has been done, and it is given in most of the books, but three things you must remember, that you have to differentiate between a cyst, a tumor, or there is a hemangioma. Always remember, supposing there is something like this, if it is a cyst, wall comes, it will go up, then straight, then go up, and then straight. It is a cyst. If it is an hemangioma, it will come like this, go seesaw, and then it is a hemangioma. And if it is a tumor, then it comes, absorbs into the tumor and just dips down. So angle kappa becomes very large. So that becomes a tumor. You are dealing with a tumor. So that is why I have kept these three. If you see here, this is a cyst. This one is a tumor. See here, the peak just goes down. This is angle kappa is so large. And here you will find it go ton, and this is basically hemangioma. And then finally, retinoblastoma you must always remember, because one of our very expert person and in a very big hospital missed the retinoblastoma at an early age and did not do any ultrasonography. There was a 2 crore compensation asked for that because the child became blind. It was diagnosed retinoblastoma at a very late stage. He was punished by the DMC for 15 days retraining of ophthalmology only for this reason. that he did not ask for an ultrasound in a patient of retinoblastoma. And here you will find that these calcium deposits will give you a tall peak, and this is a key diagnostic of a retinoblastoma case. Thank you so much.